Thus far, we've discussed Axis 1 diagnoses and dental and physical therapist treatments for these. Now we will discuss Axis 2 evaluation. Depending on the extent of findings, referring out to a psychiatrist, psychologist, or counselor may be indicated. Regardless of whether a referral is necessary, we need to be aware of the effect psychosocial components. While there is a lot we can do to affect these components, treatment strategies will not be done in this presentation. The American Academy of Orofacial Pain recommends a pain drawing of the head, neck, and jaw. The Graded Chronic Pain Scale, Patient Health Questionnaire 4, Jaw Functional Limitation Scale, and Oral Behaviors Checklist for a total of 40 questions. But if time does not allow this, then they recommend a minimum of doing the pain drawing, the GCPS, and PHQ-4. However, these three do not measure the specific functions of the jaw, so I recommend having at least the JFLS 8 item questionnaire, which measures key functions of the jaw. You can find any of these online and print them. Above, you can review the Graded Chronic Pain Scale questions. All but the last question is a 0 to 10 scale. As you can see, they focus on facial pain and its effect on the patient's life. Again, the GCPS focuses on the effect the facial pain has on the patient's life. I'm not going to read all the questions from these scales, but I wanted all the questions here so you can get an idea of what these are evaluating. Here are the PHQ-4 questions. The person ranks it on a 0 to 3 scale ranging from not at all to nearly every day. This is important to know early how distress, depression, or anxiety may be affecting the patient. This shouldn't be just performed if we think the patient is distressed. These questions are the screen. There are more questionnaires that can be used for an even further comprehensive evaluation that are described in the RDC paper I referenced earlier, and in the book, Orofacial Pain, Guidelines for Assessment, Diagnosis, and Management, 6th edition, produced by the American Academy of Orofacial Pain. But that is, again, is only if we think that there's need for more comprehensive evaluation. We can look up those there. As you can see here, the JFLS 8 addresses common areas of functional limitation that patients with TMD can have. As you can see here, the oral behaviors checklist has several other areas addressed that the JFLS does not. This does not address chewing, hard foods, as the JFLS does, but has many parafunctional activities, which are activities of the jaw other than eating, speaking, drinking, and breathing. These are the rest of the 21 questions of the OBC. To be clear, the role of these evaluations is to understand the patient, not to make a psychiatric diagnosis. Depending on the severity of the GCPS, pain drawing, or PHQ-4, you may decide to use other Axis 2 evaluators that you can find in the RDC paper or refer the patient to a psychiatrist. Which type of table should someone with TMD symptoms end up on? When should you be lying on the dentist chair on the left or on the physical therapist table on the right? Always start on the table on the right. Lying in the table on the left should be second-line care. Dentists can prescribe medication, perform surgery, injections, and make appliances. This is my final slide in this presentation. This is figure 11 in a proposed diagnostic classification of patients with temporomandibular disorders, implications for physical therapists, which was published by JOSPT by Harrison et al. In 2014. Obviously, this assumes that the patient is seeing a physical therapist. However, it can apply to any healthcare provider who is evaluating the patient for orofacial pain. The first decision that should be made is whether the patient is appropriate for conservative care. If they are, then a physical therapist should examine the patient. A referral will be made if imaging or laboratory testing is needed, or if an appliance, medication, injection, or surgery is recommended. With these referrals, normally co-treatment is indicated. If solely a referral is necessary, then this is for conditions other than TMD that is insidious in nature. As you can see in the top box, this includes disorders or conditions that may require another healthcare professional to evaluate. Following this slide is my list of references. I'll scroll through but for more specific information, don't hesitate to contact me. I love discussing orofacial pain and TMJ related complaints.